It's my pleasure to be able to introduce our speaker for today, Dr. Jennifer Haythe. Jen is undergraduate at Harvard, did her medical degree at Columbia, and received her degree in 2003. She did her postgraduate training all at the New York Presbyterian Columbia University Irving Medical Center. Trained in cardiology and heart failure, and is now a member of the faculty uptown. Jen is the Irene and Sidney B. Silverman Associate Professor of Cardiology in Medicine at the Columbia University Medical Center. She is the director of the Adult Pulmonary Hypertension Program, director of the cardio-obstetrics program, co-director of Women's Health Center, and occasionally you can find her on some of the local TV channels as an expert. The title of Jen's talk today is Cardiovascular Disease in the Aging Population, Treatment Strategies, and Recent Advances. It's a pleasure to introduce Jennifer Haythe.
I'm not sure why it's double. It looks like it's in two places.
Yeah. It looks like the little one should be the big one.
No, it's not. It's not
The little one is where she's going to be talking.
Yeah, this is not a big one. These are slides.
Oh.
All right. Is this working? So much. That was so nice. I feel like I still have to call you Dr. Drews and Dr. Lewis because my both of whom were my teachers over the years, many years ago. I was telling a story when I came in that I went to see Dr. Lewis when I was in medical school because I thought ALS because my eye was twitching, and she did a proper neurologic exam and reassured me I was fine. So I want to talk to you guys today about cardiovascular disease in the aging population, and I think I tried to make the talk so that both physicians and non-physicians hopefully will be able to follow very easily. And hopefully, if you have any questions or want to stop and go back to it. So first of all, I think one thing people don't understand is what is heart disease and what is capsular heart disease. So the most typical form of heart disease that we know about is atherosclerotic heart disease, which causes what we call ischemic heart disease. That's people who develop plaque in the arteries of the heart that lead to small heart attacks, big heart attacks, and then they develop complications from that. There's valvular heart disease, where one or more of the four valves in your heart can be affected by myriad things and cause problems. Hypertensive heart disease. Can you hear? That's better. Hypertensive heart disease, which is chronic changes to the heart that is caused by chronic high blood pressure, often poorly controlled high blood pressure in much of the population in the United States. Arrhythmias, specifically atrial fibrillation, which affects many people, especially as we age. And then, of course, what I do is heart failure, which is divided into several categories. So people can have what we call congestive heart failure, systolic heart failure, where their heart function is reduced. You can have something called heart failure preserved ejection fraction, where your heart function appears normal, but
I have a reduced ejection fraction.
Oh, better to have. But it's not reduced. And then there are all these other forms of cardiomyopathy. There's genetic cardiomyopathies, hypertrophic cardiomyopathy, basketball players who drop dead playing basketball, those kinds of things. And then amyloid is something that's particularly relevant to the aging population. And there's a lot of attention around it now because it has been probably very underdiagnosed for a long period of time. And now there's pretty incredible medication to treat it. That's also very expensive and making some people lots and lots of money. So that's why it's also very popular to talk about. So the basic risk factors that we've all learned about over time are hypertension, high cholesterol, tobacco, diabetes, obesity, sedentary lifestyle, and unhealthy diet. And those were the same things that I learned about, when I was in medical school 20 plus years ago. And that stays the same. Some of these are not, modifiable, and some are modifiable, but these are all risk factors that everyone can potentially have. One interesting thing is that we're starting to really focus on what are some risk factors for women that are different than men. So there's sex specific risk factors like premature menopause, the drop in estrogen associated with that, gestational diabetes, hypertensive disorders of pregnancy, preterm delivery, polycystic ovary, and then systemic inflammatory and autoimmune disorders, which are predominantly affect women. So really, doctors and primary care doctors should be taking a GYN history from all women, understanding that if you had preeclampsia or severe preeclampsia or preterm delivery, that increases your risk of heart disease later in life. Also, under-recognized risk factors like psychosocial, intimate partner violence, socioeconomic deprivation, poor health literacy, and poor environment are obviously going to contribute. These are the well-established risk factors that we talked about already, but it's very important to understand that, risk factors are still being identified, especially in an under-researched population of women, and that gender and heart disease really can have different phenotypes. So for instance, on the left, we have women and on the right, we have men. So the heart failure phenotype in women is they have a higher lifetime risk of what we call heart failure preserved ejection fraction, Takotsubo cardiomyopathy, which is what we call stress cardiomyopathy. So sometimes people have a shock in their life, someone dies, they have a huge fight with someone, they witness something traumatic and their heart function suddenly reduces, more common in women. Then the pathophysiology in women is slightly different. So women tend to have more inflammation and small vessel microdysfunction in their hearts, stiffness of the arteries than men. In women, their risk factors show a higher prevalence of obesity, stronger risk of hypertension and diabetes, and more risk of atrial fibrillation. Women tend to be more symptomatic and older with more comorbidities when they're diagnosed with a higher heart ejection fraction. Their outcomes tend to lead to poorer quality of life, more disability, although overall better survival. And they're often poorly treated or historically have been underrepresented in heart failure trials. They're less likely to receive the right therapy for their hearts. They're often dosed with higher doses than they may need because the studies were done mostly in men. They derive greater benefit from certain kinds of pacemakers, but often don't get them, and they're much less likely to get referred for cardiac rehab after a cardiac event. And they have a higher morbidity on the cardiac transplant list. So that's like a very important thing to focus on, is that we need more research into women heart disease, given that most of the research was done in men. And I don't think it was necessarily nefarious or bad. I think, the thalidomide debacle, I guess, or I don't know, the disaster of the 60s led to Congress actually passing a law that, women of reproductive age really shouldn't be included in randomized controlled trials of pharmaceutical drugs because they were worried about the risk of birth defects. And so that just led to this sort of somersaulting of not including women in any research. Men have a higher lifetime risk of reduced heart function. They're more severely affected by genetic causes of heart failure. They more often have the big kind of coronary artery disease where a big vessel gets occluded. They have more traditional risk factors. They're less affected by the socio-cultural determinants of health. They present younger with less comorbidities and a lower ejection fraction. They have a better quality of life, but a higher mortality than women, and they're much more likely to get effective treatment. So in terms of age and heart disease, so there's the risk factors and cardiovascular disease in the elderly. So we have this, figure where you have the classical risk factors, high blood pressure, diabetes, high cholesterol, and obesity. There's other risk factors like tobacco, alcohol abuse, air pollution. But then really important in the aging population is the comorbidities like chronic kidney disease, hyperuricemia, cognitive impairment, frailty, disability, and depression, which actually can lead to more complications and exacerbate cardiovascular disease, either by, having chronic volume control issues because of kidney problems, poor access to healthcare because it's harder to get to the doctor, no one to take care of, people, so they're in their homes not getting good care. Now, in terms of the overview of common health problems that affect older adults with cardiovascular disease, so they usually have 2 or more chronic diseases. They often have polypharmacy, so simultaneous use of more than 5 medications and often more than 10 medications. The prevalence is 26 to 40%. In geriatric syndrome is considered impaired function because of cumulative synergistic effect on multiple organ systems. So 10 to 60% of people over the age of 65. I think that's a broad range, but and then frailty. So frailty, we do more frailty testing now than we used to, but a state of reduced physiologic reserve in multi-organ systems, increasing susceptibility to stressful events. So, people who are very thin, who, can't get up from a chair themselves without using their hands, like little small basic qualifying factors of frailty can actually significantly impact your outcome with cardiovascular disease. So when we look at the management of cardiovascular disease, we definitely want to have a comprehensive assessment in all patients first, followed by management. So the cardiologist expertise will be, cardiovascular disease severity, what other cardiac complications have there been, what are their modifiable risk factors, and then if you can have a geriatrician as well involved, they can talk about multimorbidity, polypharmacy, geriatric syndrome, and frailty. And so we want to be in the successful aging rather than the accelerated aging area here by taking control of our strength, treating our underlying risk factors well, being very aware of polypharmacy so people don't get confused, fall, break their hip, things that really set the older population back. And then in terms of management, you have to think about survival goals. Are people going to die of a cardiac disease, or are they going to die of something else with an underlying cardiovascular disease at the same time? And what are their ultimate goals? How do they want to die? What is their, lifestyle look like? And in their, when they think about how they want to age, do they want to not be in a hospital? Do they want to be in a hospital? Do they want to do everything possible? Do they want to just be at home and enjoy their family? So these are all things that need to come into play when we're talking about people with so many different risk factors as they get older. Now, the AHA has divided, the cardiovascular assessment into the Life's Essential 8. They added it used to be the Life's Essential 7, now it's 8 because they added sleep, which of course we know is really crucial to recovery and reducing inflammation and stress, but also it gets worse as you age, right? The aging population often has a lot of trouble sleeping, or they sleep at different times, take naps during the day, have more trouble sleeping at night. So we really need more research into understanding, does different times of sleep affect mortality, morbidity? Does it matter when you get your sleep? Is a nap okay? And if you don't sleep as late in the morning, what if you sleep great? I don't know. My mom is 86. She can't sleep at all. My dad's 86. He goes to bed. He wakes up 10 hours later. We don't understand how he gets it. So I think it depends on the person, but is there any data? We don't really know. So when we think about the aging heart, so adults the age of 75 and older is a very rapidly growing population. Heart disease is still the #1 cause of death. We see stiffening of the arteries due to hypertension. There's often many years of untreated risk factors leading to coronary artery disease. Stiffening of the heart muscle leads to heart failure. The electrical system ages as well. So we see the development of the need for pacemakers and atrial fibrillation, which can lead to need for procedures like ablations or medical therapy or blood thinners, which are also complicated for the aging population because if you fall and you're on a blood thinner and you hit your head, you can bleed, but you also want to balance that with the risk of stroke. There's calcification and weakening of the heart valves. And then we have a lot of new medicines and procedures that will hopefully not just, longevity is kind of an interesting word. Like it's how long you're going to live. But when people hear the word longevity, I think they think about being healthy as you live older, right? Everyone wants to live as healthy as they can and then die in their sleep. Nobody wants to struggle and be sick and, be in a hospital. So how do we make, that be the goal? So to talk about some of the different risk factors and the newest treatments. So for obesity, I'm sure you all have heard about GLP-1s. So GLP-1s stimulate insulin secretion. They suppress glucagon production. They slow gastric emptying and reduces hunger. There's 2 big ones on the market that are injectables. There's semaglutide or Wegovy and tirzepatide or Mounjaro. They also have other names if Ozempic is Wegovy, and Zepbound is Mounjaro. They just, depending on what the indication is, they change the name. These drugs can cause dramatic drop in body weight. They have been shown in a recent study to really reduce blood pressure, inflammation, decrease in morbidity and all-cause, mortality from any cause. And they are thought to reduce visceral fat, lower blood sugar, and cause direct vascular anti-inflammatory activities. Now, whether or not we should be using GLP-1s in the older population is still, something we need to talk about, because associated with being on a GLP-1 is the loss of a lot of bone and a lot of fat at the same time. I mean, a lot of muscle and a lot of fat at the same time, and some sarcopenia as well. So bone loss. So it's important to think, when you lose weight due to a GLP-1, as opposed to just walking more and eating a healthier diet, are you losing more muscle mass? And what we don't want to do is lose muscle mass in the aging population. And so this needs to be studied more. I'm sure they will, because the benefits certainly seem to be incredible for patients with cardiovascular disease in general. This was actually an editorial that came out in Nature recently about GLP-1s. Are GLP-1s the first longevity drugs? And the author goes on to sort of talk about how everybody's very interested in longevity and whatever that means. And, what does it mean to use GLP-1s in the aging population? Will it actually improve length of life and quality of life? Is it the right group to target with these drugs? I mean, to be honest, there's not a lot of very obese 85 to 90-year-olds around. Most people who have suffered from significant obesity die in their 60s and 70s, and they don't get to be in their 80s and 90s. So, is there a use of microdosing GLP-1s? I think this is a big area of research and may help with cognition. And I mean, it's apparently, helping people not drink alcohol as much. There's a lot of potential uses. This was the big study that came out in JACC recently. That's the Journal of the American College of Cardiology. That showed that patients with heart failure who received GLP-1s had a significant reduction in cardiovascular mortality, which was particularly pronounced in overweight and obese patients with a reduced ejection fraction. The next question is to talk about is hypertension. Yeah. I'm not sure that there was nobody that wasn't getting an effect. It was more that the benefit was greater. So you can see here, the benefit's greater if your ejection fraction was lower and your BMI was greater. Let's look here.
Oh, my statistical training always told me that when the confidence interval overlap the null line, one should assume effect in this. And I'm looking at the ones with the overlap.
That there is effectiveness.
No,
should assume no effectiveness.
No effect. I'm assuming that vertical line is no effect.
Yeah, so I think the p-value that are statistically significant are here on the way left of the null.
All right, so I can see that.
Right. So this was BMI 25 to 30, so that was the lowest BMI category of all the groups. Had the least benefit.
Okay, yeah. So I assume the implication here is if you're in good shape,
it has less benefit.
Right.
Well, it has in cardiovascular mortality.
Okay.
But in all mortality. Yeah, exactly. Right. Well, this wasn't specifically looking at older people. This was looking at all comers.
Okay.
So in patients with high blood pressure, so the AHA, put out these guidelines. They really want people to be aggressively treated for their risk factors. They want a goal of blood pressure less than 120 over less than 80. However, my experience is that the older population may need to maintain higher blood pressures. I actually allow my patients to have blood pressures of 130 to 140 over 80 to 90 often. People with long-standing higher blood pressure have stiff arteries. I often find that if we aggressively treat blood pressure in patients over the age of maybe 78, that they can get dizzy, they can get cognitively foggy, they cannot feel well, they feel exhausted, they can fall if they get too low blood pressure. So I tend to find that they tolerate and feel better with a blood pressure that's a little bit higher. Obviously, may not be true for someone who's always had low blood pressure their whole life, but then they're not on medication anyway. But in general, I'm a little bit more forgiving about how high their blood pressure can go, and in fact find that they need it to be a little bit better, a little higher. Also to perfuse their kidneys and other areas where the arteries may be stiff as well. There's also that when we treat high blood pressure, especially in patients who have really hard to control blood pressure, you get a lot of polypharmacy, which can lead to kidney dysfunction, high potassium, risk of falls. So it's something to be very mindful of. We talk about lifestyle changes. I think when you're 85, it's hard to change your blood pressure with a lifestyle change, but it's always good to have a healthy lifestyle. The accepting need for medications can always be challenging, but we really try to work with our patients to minimize the lows and the highs. Okay, high cholesterol, my least favorite topic because I feel like there's so much debate on it. Some people think statins cause dementia, that we need cholesterol because it's in our brains. I don't even ask Dr. Lewis what she thinks about statins. But we know that statins reduce the risk of stroke and MI in patients 75 and older. The statins are the typical drugs like atorvastatin, which is Lipitor, Crestor, all of those drugs. Some of you may or may not be on. I personally am on Crestor. I have a very high family history of very high cholesterol. But as a woman, I only take 5 milligrams 3 or 4 times a week. That's not how the studies were done, but my cholesterol gets very well corrected on that minimal dose. But the studies were always done in higher doses in men. So, keep that in mind that sometimes the older population and women don't maybe need quite as high a dose. And Zetia is an add-on often used or instead of a statin if patients get cramps from statins or have side effects. In patients 75 and older, Zetia lowered the risk of composite outcome with sudden cardiac death, myocardial infarct, need for coronary revascularization or stroke. And of course, the newest and the greatest is the PCSK9 inhibitors. So there's inclisiran, which is given as a sub-Q injection once, and then again 3 months later, and then only needed twice a year. And evolocumab or Repatha, which is another human monoclonal antibody given subcutaneously every 2 weeks. These drugs are very effective at lowering cholesterol without the need for statins in patients who have side effects or if compliance is an issue and it's easier to be dosed infrequently. So what is atrial fibrillation? Atrial fibrillation happens to many aging people and can cause a lot of problems and complications. So just to remind everybody that when we're looking at the heart, we have this is the left atrium, the left atrium, the right atrium, the right ventricle, the left ventricle, and that normal heart impulses are generated in the atria and conducted to the ventricle through a node. And what happens with AFib is that the atria gets stretched out, and rather than one specific impulse being conducted, the atria starts to fibrillate and release multiple impulses. And some of those gets trapped on the way to the ventricle in the AV node and become refractory. And so that's why people who are in AFib can have a very fast heart rate if it's transmitting through the AV node quickly, but irregularly with some being blocked. And so, you feel your heart rate is kind of all over the place and it can get very fast, but it can also become very slow as well. There's 2 different strategies for AFib to control the rhythm or control the rate. So there's drugs that can slow the heart rate down, but sometimes as we age, it can slow the heart rate too low and people can need a pacemaker in order to manage their AFib. So in order to be on the drugs that allow you to slow the heart rate down, you'll need a pacemaker to have as backup in case you get too slow. So you can see that untreated high blood pressure or drinking too much wine your whole life or whatever the risk factors leading up to it, and then you get AFib and now you have these other problems, right? You're going to need a pacemaker maybe, you're going to need drugs to slow your heart rate down. And all of these things may make the aging person not feel great. The other thing is that atrial fibrillation causes an increased risk of stroke because the fibrillating atria can cause clot to form. And that's why people who have AFib are often put on blood thinners like Eliquis or Coumadin or Xarelto to prevent the risk of stroke. Now, treatment options include, newly diagnosed AFib, you might get a cardioversion where they bring you to the cath lab, they do a special echo to see if you have any clot in your heart, then they shock you back into a normal rhythm. Sometimes we just control the heart rate because the studies have shown that rate versus rhythm control are pretty equal in terms of outcome. And then there's ablation. So I know some people in here may have already had an AFib ablation, but there's now 3 different kinds of AFib ablations. This is where you get a procedure. This is the picture here on the right where they isolate the area around the pulmonary veins where these abnormal impulses come from, and then they ablate them to try to stop the AFib. So there's radiofrequency ablation, which is in the image of A. There's cryoablation, which you see in B. And then the newest form is pulse field ablation, which is here in C. The nice thing about pulse field ablation is that it's ultra rapid, high amplitude electrical pulses that desiccate tissue without significant heating of the tissue, which seems to be more specific to cardiac tissue, and it seems to work better with fewer side effects. So if anybody needs an AFib ablation, you should certainly be asking about whether the place where you're getting it done does pulse field. I don't want to spend too much time on coronary artery disease because I don't think it's that interesting, but basically, this is a picture of what, a normal artery should look like, the LAD with the arrow and the left circumflex. These are the big arteries of the heart, and you can see 2 blockages there, and then on the right side, the right coronary artery, you can see a blockage there, and basically, you get atherosclerotic plaque. There's poor blood flow through those arteries. Sometimes if a plaque ruptures, you can get a heart attack, often treated with stents. The stent technology hasn't gotten that interesting recently. It's better than it used to be. We used to use bare metal stents. Now we have stents that are coated in different drugs that prevent them from closing. In terms of valve disease, so this is also very important for the aging population. So just a reminder on the bottom right, our heart has 4 valves. There's on the right side of the heart, we have the tricuspid valve and the pulmonic valve. On the left side, the aortic valve and the mitral valve. And the aortic valve in particular often gets calcified as we age. And traditionally surgery was done. A surgical aortic valve replacement was done. Very safe surgery, very well tolerated. I don't know how many years ago now, 15 years ago, Columbia was like a pioneer with Marty Leon and Craig Smith, actually, who was a great heart surgeon, and Marty Leon, who was an interventional cardiologist, and they created these famous partners trials where they looked at these new transcatheter aortic valve replacement. So that's where rather than having open heart surgery, which was a very well tolerated, very safe procedure, what would happen if you tried to deploy a valve through the leg into the heart and crush the old valve to the side and put in a new valve? And what was interesting is that, of course, this is an interesting study because surgeons have a lot to lose, right? If this doesn't go, if the TAVR is better, then they're going to lose like a huge percent of their patient population. And they systematically studied, very old, high-risk patients, like in their 90s, who, couldn't go for open heart surgery, and they did really well. And then they went, to the next stage group, and then they went to the next stage group, and they've all been shown in basically every age group TAVR was superior. Now, you're not going to get a TAVR if you're 35 because the TAVRs only last 6 or 7 years max, if that. They're not long-lasting valves, but better if you can't really have open heart surgery because of age or other risk factors, or you don't want to. 6 or 7 years isn't so bad to get out of the valve. So we have a couple of different valves. So this is the partner trial. So just to review, a catheter comes up through your aorta, goes across the diseased valve, okay? Then the interventional cardiologist, or it's usually, we used to be a surgeon also, can put the artificial valve inside the diseased valve, and then they inflate a balloon. So it crushes the old valve to the side, and then they pull out, and you're left with this new valve, which is very cool. And what's interesting about it is that you need to have something to anchor the new valve on. So aortic stenosis is associated with a lot of calcification. So you can anchor the new valve when you have aortic stenosis. But people who have leaky aortic valve, they tend to not have all the calcification. It's usually a different problem. And so TAVR wasn't studied in that group at first because you don't have anything to anchor the valve against. But they're now trying to do more studies in that. So TAVR is a really great option. Now we have also for the mitral valve. So the mitral valve is a much more complicated valve. It has all these things coming down from it, but it has lots of leaflets. But They have something now for people who have a very leaky mitral valve called the mitral clip, which was studied also very extensively in patients with heart failure. And when is it safe to use the mitral clip? When is it not safe to use the mitral clip? And it showed that it did make people feel less short of breath, and they had a shorter recovery for the treatment of, severely leaky mitral valves, assuming your heart function wasn't too reduced. So you're really at the end, it's not going to help you. But if you're in that middle zone, it's helpful. But again, very high level expertise needed to deploy these valves the right way. The one being studied most recently is this TriClip, or transcatheter edge-to-edge repair of the tricuspid valve. That's on the right side of the heart. And they basically put the valve in and kind of ensnare and draw the edges of the valve back together. And again, can only be done in this patient population that falls somewhere in the middle, where they're not too well and they're not too far gone and sick, or they don't have high pressure in the lungs. In terms of heart failure,
This valve only lasts 6 or 7 years. What happens when it begins to fail and you're still otherwise healthy?
Right. So we don't normally put a TAVR in someone who, so if you're 65 and you need a valve replacement, you're still going to get a surgical aortic valve. You probably get a tissue valve that'll last 8 to 10 years. If you're under 50 or 45, you'll talk to your doctor about getting a mechanical valve. Those you have to be on a blood thinner for life, but they last 25 years. But if you're in your late 70s, 80s, and you really don't want open heart surgery, which you could still get you certainly could get a tissue valve with open heart surgery, like a traditional aortic valve replacement in your 70s, and it probably will last you forever. But if you're 85 and your life expectancy is 5 years, but you're saying, like, if you get to 90 and the valve isn't working, but you're still a high functioning 90, so you can sometimes do a valve and valve TAVR. So they can put a valve inside the other valve. So now you're like stacking valves, but the problem is you can't put too many valves in valves, because then the hole becomes too small and it starts to develop the stenosis problem all over again. Yeah. But often we put, sometimes TAVR is the only option for someone who's had an aortic valve, and then they're too high risk to take back, 10 years, 12 years later, and they can do a TAVR, like a valve in valve, which is cool. And then the other thing that is important which is if it gets infected, right? So we still need the heart surgeons to be able to go in and remove the valve apparatus and replace everything and fix everything up if you get a bad infection on one of those heart valves. Because once you infect a prosthetic valve, that's problematic. Usually not going to be treatable with just antibiotics. Yeah, but I mean, it's not a perfect solution. There are definitely people who get a TAVR and then in 6 or 7 years, you're like, what now? I hear what you're saying. But usually, we don't really even totally know how long some of them last. Some go on much longer. It depends if you have other risk factors that increase your risk of the valve falling apart. Like if you have kidney disease, the valve gets calcified faster. Because patients with kidney disease tend to have a lot of high calcium. Lastly, heart failure. So there was a lot of drug development early on in heart failure, the latest drug therapies, and there was nothing for a while, and then there was a new burst. So we have the major classes to treat systolic heart failure are the ACE inhibitor, angiotensin receptor, and now the angiotensin receptor inhibitor called Entresto, which is a combination of sacubitril and valsartan. So if anyone here has heart failure, you're probably on Entresto. That means your ejection fraction of your heart is like less than 55, 50. You may live in the 20s, 30s, or 40s. The SGLT2 inhibitors, like Jardiance or Farxiga, are sort of initially diabetic drugs, but then were shown to significantly improve like breathing and outcome and mortality in patients with heart failure. So that's one of our staples. Beta blockers have been staples for a long time. Metoprolol and carvedilol are the two predominant ones used in heart failure. And then mineralic corticoid receptor antagonists like eplerenone and spironolactone. And then in terms of procedural therapies, biventricular pacemakers that synchronize the heart muscle. So patients who have heart failure who have dysynchrony on their EKG and having wide QRS, we call it, so their heart is not contracting at exactly the same time because the right and left side of the heart, so the heart gets very dilated, and so one side might contract a few like a millisecond before the other. But if you resynchronize that together, you can improve heart function, especially in women. Defibrillators, if your heart functions below 35%, they'll put in a defibrillator to give you a shock if you develop a potentially malignant arrhythmia. And then one of the newer devices we have is a CardioMEMS device, which sits in your pulmonary artery, and you lay on a pillow, and it monitors what the pressures in your heart are, and it can help tell your doctor how much diuretic you should be on. So we have a new program now called, the outpatient remote heart failure program, where patients get, so this is a pacemaker, we'll talk about that after, but they get a pulmonary artery sensor that's put into their pulmonary artery through a catheterization. It's wedged into the sort of wall of the pulmonary artery. And then you get home and you lie on this pillow, and it transmits your pulmonary pressure to the hospital doctor. And then they say, well, your pulmonary pressure is a little high. You should increase your Lasix, your water pill from 20 to 40 or 40 to 80. And a lot of the patients' water pill management is done that way now, so that they don't have to come into the hospital every time or call the doctor every time. And it's get much more effective at keeping patients actually out of the hospital, which should be everyone's goal. And then this is a biventricular pacemaker. So just to review, a pacemaker usually put in here, although now there are sub-Q pacemakers, but the older population probably not going to get that right now. The pacemaker goes in through into the vein up here, down into your right atrium, right ventricle, and sits in your right ventricle, pacing on the right side. And then you can also have a left-sided lead that goes to the coronary sinus, and that's the biventricular pacer that contracts on both sides of the heart. We have LVAD pumps. At Columbia is an LVAD site, actually one of the also pioneers of all the studies. So this is also what Dr. Drusen used to do with what I do now. Take care of patients who get this pump put in. So patients with advanced heart failure who either are waiting for transplant, too sick to wait for a transplant, or can't ever get a transplant because they're too old, or they're smoking, or they have other things that preclude them from being listed for transplant. The surgeon takes them to the operating room. They stick this pump on the apex of the left ventricle. This pump sucks blood out of the apex and sticks it back into the aorta. So it basically bypasses the failing ventricle. The patient wears so this drive line, which is the power cord, actually comes out through your stomach. So you actually have a power cord, and it connects to the controller. These are your batteries that you wear like on a vest. And it looks and sounds terrible, but in many patients, we have patients that live for 15 years with this, going golfing. You're connected to batteries and a pump, but it's better than dying. So in many patients, if you're 75 and you get really advanced heart failure, you're too old to be listed for transplant. Yes, so the biggest risks of the LVADs was stroke or clot or infection. Those are the big ones, right? So they've traditionally always been on Coumadin and aspirin. There was recently a big study where it was shown in the newest device called the HeartMate 3 LVAD that aspirin didn't make any difference in outcome or stroke or bleeding. And so no longer do they need a baby aspirin unless they have another reason to be on a baby aspirin, like something else. And then the INR goal of Coumadin, so they have to be on Coumadin. They can't be on the Eliquis or these other blood thinners that are easier. It's still Coumadin is superior. So you have to get your blood checked. But the goal for the Coumadin is lower in the HeartMate 3. It has a much lower risk of bleeding and stroke in general. So some patients even we stop blood thinner altogether if they've had a lot of bleeding problems, which some do, because the LVAD actually can chop up von Willebrand, and so they get something called acquired von Willebrand factor, where they have a tendency to have stomach GI bleeding because of the VAD, because it's chopping up your von Willebrand factor, which is one of your clotting mechanisms. So it can provide people as a bridge to transplant. I have a young guy I have young patients who have LVADs because sometimes people show up in cardiogenic shock and they need some kind of a bridge to survival, just to survive because they're too sick for transplant. And so I think one day the hope is that we'll have an LVAD that doesn't need to be plugged in, right? It's like it has its own battery, you can charge it, maybe right like standing next to a charging station. For now, the biggest issue is that this hole, right, which leads the drive line up to here, is a source of infection. And it has to be kept really clean, but people can develop deep device infections that are complicated and require like drainage and incision and chronic antibiotics. So there's always some trade-off. The other thing is my young patient who has an LVAD likes it because he doesn't have to take any heart failure medication or transplant medication. You know, heart transplant is a great thing for many people, but you are trading one disease for another, right? So you're going to take medicines that suppress your immune system, that give you infection, that can affect your kidneys. And if you're 35 and you're able to manage the LVAD pump, you're delaying maybe 15 years of all those drugs that can affect your need to kidney transplant down the road. So sometimes it's like a longer survival predicted with an LVAD first if you're young, and then, you know, check. And then I'm going to end by talking about amyloid, which I think is really a topic of interest to a lot of older people. A disease that has had increasing awareness and has treatment. So really important that if you have it, you get diagnosed. So amyloidosis comes in two forms. There's ATTR amyloid and there's AL amyloid. Amyloid happens when proteins fold incorrectly and then lead to buildup in different areas of the body. One area is the heart. The deposits in the heart make the heart stiff. So you may have a normal functioning looking heart on echo, so your ejection fraction is normal, but the heart's very stiff and it doesn't relax well. And I kind of liken it to when you blow on a kid's balloon, if the balloon is really soft and easy to blow up versus like a thick balloon where you're pushing, you know, you're trying to get the balloon to open. A stiff heart basically can't relax well, and so it doesn't fill well for each additional heartbeat. And so ATTR amyloid is made, transthyretin amyloid is made in the liver, and AL or light chain amyloid is made in the bone marrow. So the amyloid can be made in two different parts of the body. Here's the ATTR being formed in the liver. This is the normal structure. Then it becomes misfolded. It forms these fibrils and then deposit in the heart and lead to heart failure. And in AL, the bone marrow has like a plasma cell dysplasia, or like it's on the spectrum of myeloma. You get these excess immunoglobulin light chains that misfold into their fibrils and deposit into the heart. And probably undiagnosed in many people for many, many years until now, where it's becoming very much more recognized. So ATTR amyloid, which is called age or senile amyloid, is what it's referred to as, is the most common type in people over the age of 70. It's caused by the transthyretin protein. There's wild type or age-related that happens in men, especially with aging, and then there's hereditary due to a gene variant that often runs in families. Associated syndromes are carpal tunnel syndrome, biceps tendon rupture, spinal stenosis, and heart thickening with low voltage on the EKG. So if you've had any of those things, you may also have amyloid. And I'm not trying to scare everyone who's had carpal tunnel, but it really is associated with these things. And the new treatments are, so there's tafamidis, which is a drug that stabilizes the transthyretin protein and doesn't allow it to misfold, and it slows disease progression. And now we have new drugs, which are gene silencers, which are being studied, patisiran and vutrisiran, given as infusions. And we know that earlier diagnosis leads to better outcomes. In terms of systemic manifestations of ATTR amyloid, so you often can get dark floaters, glaucoma, dry eye, they have spinal stenosis, patients develop kidney problems with protein in the urine, bilateral carpal tunnel syndrome, peripheral neuropathy. There can also be effect of the amyloid protein on the nerves that, you know, in your legs and arms, so people can have neuropathies. We just talked about all the heart manifestations. There's autonomic neuropathy, so people who have orthostatic hypotension, especially older people, you stand up and get lightheaded and feel like you're going to faint. Recurrent UTIs due to urinary retention, sexual dysfunction, sweating abnormalities, and nausea and vomiting. And then they can also have it in their gut. So GI manifestations are nausea, vomiting, diarrhea, constipation, unintentional weight loss. And this is interesting. The number of physicians seen before a patient receives the right diagnosis is greater than 5 physicians seen in 30% before the right diagnosis is made. So traditionally very underdiagnosed. I think getting better now, and AI is interestingly making it even better. They're doing studies on EKGs where they're looking at EKGs with low voltage, and the AI machine is picking up like this patient could have amyloid, they should get an echo. Yeah. Yeah.
AL is usually light chain protein, so what are you looking for?
So with TTR, so you start, everyone gets a kappa lambda light chain assessment, like a blood test, and an SPEC, like a serum protein electrophoresis. And then depending on those results, if there's no light chain, like an amyloid suggestion, there's no spike, you get something called a PYP scan, which is a study that basically diagnoses you as likely having amyloid, and then you should get a biopsy. And a biopsy of your heart or your kidney is the heart's a much safer biopsy in people with amyloid because their hearts are stiff, it's less likely to have complications. But you need a biopsy to diagnose. But it's usually and the biopsy is usually very positive, Congo red stain on the microscopy, but on the microscope. But anyway, so that's how you diagnose it. Or kidney biopsy, fat pad biopsy. Now AL is in the myeloma spectrum, so bone marrow biopsies, things like that. So here's organs involved with AL amyloid. So more traditionally, AL causes macroglossia, which does not happen in TTR, where patients have a large tongue because of infiltration of the AL amyloid protein in the tongue. And they can get this purpura around their eyes, so like what looks like bruising around the eyes. Again, the heart, the malabsorption, and autonomic neuropathy, enlarged liver, kidney problems, nervous system, those are all the same. It's the tongue and the purpura that are specifically different to AL. So this is one of the AL amyloid treatments. So we talked about for TTR amyloid, we have tafamidis, and we have these gene silencers. For AL amyloid, it's like chemo. You need to get real chemotherapy because it's like you have a bone marrow plasma cell problem. So the main study is the daratumumab. I know it's like too many consonants. And so this was put out, I think this is the Mayo Clinic protocol. So patients with newly diagnosed AL amyloid, are they candidates for an autologous, like a stem cell transplant? If they are, they do induction with daracibor, which is a chemotherapeutic. If they're not eligible, then they just do the chemo. But I mean, you can be cured with a bone marrow transplant with your stem cell, which is kind of crazy. So anyway, just to wrap things up, the take-home lessons are always treat your modifiable risk factors, be screened frequently when you have non-modifiable risk factors, like one of your parents dropped dead when they were young, eat a healthy Mediterranean diet, exercise, meditate, and sauna. We didn't really talk about these, but there's a lot of data to show that meditation and sauna is really helpful for lowering blood pressure, reducing heart rate. Don't be in there too long. And the most important thing, I think, for longevity, maybe even more than all of this, is spending as much time outside and with friends doing activities you like, because that has been shown to actually really improve not just longevity, but quality of life. That they did studies that showed that people who had friends and they got together like you are, they do activities together that they enjoy, they play backgammon, they play whatever, Mahjong or whatever those games are, that people like that not only lived longer, but felt happier. Anyway, that is the end of my talk. So, anybody has any questions?
Didn't touch on.
Okay.
The FDA is about to remove the black box warning for
Hormone.
perimenopausal women with hormonal replacement.
Yeah.
How much of a risk is it, and what advice are you giving your patients?
So interesting. So women in their 80s should not start hormone replacement therapy. That is not what this is meant to do. So basically, they 25 years ago realized that women didn't seem to have heart attacks at the same rate as men until they were older and post-menopause. And why was that? So they thought it was maybe estrogen was protected. And so they had the nurses studied this big women's heart initiative, and they really misinterpreted the data. and said that hormone replacement was associated with heart disease and heart attack and stroke, and that women shouldn't be on it. So they took everyone off, all the women came off of hormone replacement therapy. And then when they reanalyzed the data, they realized that really the people who were at risk for heart attack and stroke on hormone replacement were women who were older, who had a lot of risk factors for heart disease anyway, and who were started on hormone replacement later. So removing the black box warning is really great for all of these women now who should get hormone replacement therapy and not be afraid to be on hormone replacement therapy, because it's actually very effective and good. But if you have prior heart disease or you have hypertension, diabetes, and high cholesterol, then you probably shouldn't be on hormone replacement therapy. But I'm not worried about the black box warning being removed. I think that's a good thing.
I have more of an editorial comment than a question. Thank you. I don't know what's going on.
Hello?
No, I'm right over here.
I mean, oh, sorry. On the screen, I'm like, who's talking?
And I was wondering what you were looking at. Part of this is just an editorial comment because I spent a good part of my career working on recognition of women's health and women's occupational health and other really prejudices of the research establishment that just said women's work was safe and women had this or that. And the thalidomide thing happened because of the mythology that somehow the uterus was protected with some mysterious barrier. And it wasn't until thalidomide that the first reproductive toxicology studies ever started being done.
Huh.
And so and a lot of what you showed with preeclampsia and heart disease, I have to wonder how much of that are shared biochemical factors and how much is just the prejudice of the models and what we choose to measure and how we choose to measure them. And I think that a lot of these it's very disease causation is very complex. The arrows go both ways. It's very hard to tell correlation from causation, and it's hard to tell cofactors. And so
Yeah.
But what I really want to talk about was sleep, because I think this the way that we sleep since the beginning of electricity has really changed from the way all of human history was and all the time that people slept, and it's too easy to characterize it as an illness that your sleep pattern has somehow changed. This morning I went out at 5:30 in the morning in my backyard and got all the leaves I finally got around to before the rain came, because I'm up at 5:30, and now I've started texting to all my other friends who are also up at 5:30 in the morning. So I think that rather than diagnose or make people think that there's something wrong, maybe we should be having these meetings at 6:30, and we can all have breakfast together. So we classify too many things as diseases.
Yeah.
And then my other big question is, why are people taking 10 drugs? And name any study that has looked at the effect of these 10 drugs and health outcomes, and there isn't any. So
Right.
If I had heart disease, I would want to come to you and want to put all your little pins in or whatever. But we really need to have a better analysis of what we're analyzing and how we're analyzing.
Right. Well, I think what happens is you start to treat, you need these 4 drugs to treat this, and you need these 2 for this, and this 2 for this, and these 2 for this, and before you know, you're on 12 drugs, and yeah, you're right. And also with sleep, I think sleep is important, but it may be that some people get up at 5 a.m. and that they take a nap in the middle of the day, and that contributes to their sleep, and then, as long as they're feeling okay and not exhausted. But yeah, the other thing about pregnancy is I think pregnancy is now seen as a stress test, and that the stress of the pregnancy and the volume that shifts that go with that and what happens to the heart during that is real. But to your point, they did a study on outcomes of pregnancy in Black women who were first generation, so their mothers, right, came over to this country. These are from another country, and their mothers had no history of preeclampsia or preterm labor or anything. This was in the New York. This was a big study, ProPublica, I think, in the New York Times. And then they looked at the first generation of their daughters, and they all had hypertensive disorders of pregnancy, preeclampsia, preterm labor, stillborn. And the question was, and was this, what was the cause? So they tried to, control for everything, like socioeconomic status, diet, all these things. It seemed like it was just the sort of social effects of racism on their outcomes rather than it being diet specifically, because it happened no matter what. That the risks in Black women was much greater. I don't know if you all saw that recent video of a woman who presented to a hospital in Texas who was Black, who was in labor, and she was basically treated like garbage and, not like it was a medical emergency, which it was. So I think you're right. I think it's hard to always pin causation on, we don't know what came first or which affecting what.
And the last thing I want to say is I haven't had, now that I get to get ChatGPT to do this fast, is that I would love to see an age study of who's doing longevity studies. And I bet that the average age of people in their 40s and 50s, and that there's not a whole bunch of people who are much older worrying about how to increase longevity. It's just younger guys who want to live forever.
I can tell you who's doing the Novo Nordisk, and that's who's doing the studies on longevity, because they want to make people live longer. Any other questions? All right, thank you.
Thank you. This is changing the subject, but in the 60s, mitral valve disorder or leakage and stuff was very common. And I think it was because of rheumatic fever.
Mm-hmm.
And I'm not sure about the mechanism of all of that, but what's the prevalence now? And I think I've read and heard that rheumatic fever is on the upswing, at least in some areas. And then I'm assuming we'll see more mitral valve problems.
So rheumatic heart disease, like you're talking about, basically happens if you get a strep infection that's not treated properly. And so there was certainly rheumatic heart disease in this country, but as soon as antibiotics were invented and people understood it, it's not that the rheumatic fever episode when you're 8 causes a heart problem. It causes a trigger of an inflammatory problem that over time leads to calcification of your heart valve, specifically often your mitral valve. And so often we see young people who have rheumatic heart disease traditionally come from countries that have poor healthcare. So I get patients who have come from Ecuador, or Guatemala, or South America, or Africa, who probably had strep and never got antibiotics, and now they're 25, 30, and they're pregnant and they have rheumatic heart disease. But if it's I don't know if it's on the rise in this country again. If it is, it would be because of lack of access to care and treatment that are resistant. That may be true too.
And now becoming resistant to penicillin.
Right. I mean, mitral valve disease, rheumatic heart disease is a major cause of valve disease, but then aging is a different cause, right? Or heart failure can also, as the heart dilates, it pulls the valve apparatus apart, and people can get leaky valves from that. Yeah. I have. Yeah.
It's very interesting, and it points out the idea of family connectedness and friends, and then exercise. The two things that they find in the different blue zones are where significant proportion of the population lives into their 90s and 100s. Mm-hmm. They tend to be hilly, so these people are exercising all the time, and they have very close friendships, which I thought was very interesting.
They do, and they climb the hills often to go to church, or like in Italy or wherever they are, and there are these really long windy hills, and they're in their 80s going up the hill in 90-degree weather, and they seem to make it, but yes, I think it's constant activity, and I think spending a lot of time outside, which is happening less and less, unfortunately, I think, in our society.
Thank you.
Yeah.